Thank you for joining this brief overview of the Illinois Medicare-Medicaid Alignment Initiative. My name is Bruce Lederman, and in this presentation, I will review how the healthcare delivery system for dual-eligible beneficiaries in Illinois is being redesigned to become one that is more person-centered with a focus on improved health outcomes while reducing cost growth. With the voluntary enrollment period beginning on January 1st, I believe that you will be hearing more about this demonstration in the coming months. So let's get started. Medicare is the federal program that provides health insurance to older adults and certain people with disabilities. It is paid for by two federal trust funds and covers physician visits, medication costs, and hospital and post-acute service costs. It does not provide for long-term services and supports, or LTSS as it is also called. Medicaid, on the other hand, is a joint federal and state program, and it provides health care coverage to people with low incomes who also fall into certain categories such as children, pregnant women, older adults, or the disabled. It also pays for long-term services and supports. Now, because Medicaid is funded by a combination of federal and state dollars, eligibility requirements and Medicaid benefits vary among the 50 states. There are a number of individuals who are beneficiaries of both programs. They are technically referred to as dual-eligible beneficiaries, and often the shorthand duals is used. There are a variety of reasons why someone would qualify for both programs, but in general, either an individual was qualified for Medicaid and became additionally eligible for Medicare once they reached age 65, or at some point after reaching age 65, the individual became eligible for the Medicaid program due to changes in their financial resources. The majority of the 9 million duals are over the age of 65 and are among the sickest individuals covered by either the Medicare or Medicaid programs. These are people with complex health and long-term care needs who have their acute medical care expenses paid for by Medicare, while Medicaid covers their premiums and other expenses, and for those who meet asset and income thresholds, their long-term service and support needs. In its annual report to Congress, the Medicare Advisory Payment Commission noted that because the Medicare and Medicaid programs have different regulatory and reimbursement schemes, current coverage and payment policies for the duals incentivizes cost shifting and hinders efforts to improve quality and coordination of care. In 2010, there were approximately 338,000 duals in Illinois, and Illinois Medicaid expenditures for this population mirrors the data shown on the slide for national Medicaid expenditures. On the national level, duals comprise 15% of those enrolled in Medicaid, but are responsible for 39% of spending for that program. Similarly, this disparity also exists in the Medicare program, where duals only constitute 16% of Medicare enrollment, but are responsible for 25% of Medicare spending. Duals are a diverse population with complex care needs. Half of the Medicare duals are in fair or poor health, and that is more than twice the rate of other Medicare beneficiaries. As a group, duals are more likely to have mental health needs, more likely to have less than a high school education, and are more than twice as likely to be a member of a minority population. Here's something else to consider. Duals are 7 times more likely to be receiving long-term services than non-dual Medicare beneficiaries. So in response, the legislation creating the Affordable Care Act included the creation of 2 new federal offices to explore how to improve access and delivery to care and control growth in spending. The Federal Coordinated Healthcare Office, also known as the Coordination or Duals Office, and the Center for Medicare and Medicaid Innovation, also known as the Innovation Center. The Coordination Office seeks to improve the alignment of care between the two programs to improve the quality and lower the cost of care to dual-eligible beneficiaries by funding state demonstrations. It is projected that in the next 25 years, total Medicare and Medicaid expenditures will double as a percentage of GDP. The hope is that the demonstrations funded by the Coordination Office will provide the necessary interventions to diminish this trend. While the Coordination Office is keeping busy aligning the Medicare and Medicaid programs, the Innovation Center is busy developing new payment and service delivery models and is currently funding 28 states to implement strategies for payment reform. The demonstration project we are about to talk about is one of those innovations. In June, the Innovation Center approved 6 states to participate in a new demonstration which will last 3 years, and it's anticipated that the national enrollment will grow to 2 million beneficiaries. California, Illinois, Ohio, Virginia, and Massachusetts will be testing a capitated payment model of reimbursement, while Washington State will be testing a fee-for-service model. Voluntary enrollment in Illinois is scheduled to begin on January 1st, and some consider this to be an ambitious goal and have suggested that Illinois should follow the recent example of California, which decided to delay enrollment in its own alignment initiative for 4 months. Now, the goal of this demonstration mirrors those of the others around the country. 1, to unify the administration process so duals can seamlessly be able to enroll and disenroll in both programs. 2, to improve the care coordination between Medicare and Medicaid to avoid the unmet needs and underutilization of community-based services that is now occurring. And 3, to integrate financing between the 2 programs, which is also hoped to facilitate care coordination. Ultimately, by relying on a managed care capitated model with increased care coordination, the initiative hopes to achieve real cost savings to both the Medicare and the Medicaid programs. How much money really can be saved? Will managed care organizations be able to fully coordinate the complex needs of this challenging population? Will community-based providers remain a viable option? These are among the many questions that community-based providers and elder care advocates have for the Illinois Department of Healthcare and Family Services, and hope they will be able to address over the coming months before enrollment begins on January 1st. All right then, well, thank you very much for watching my presentation on the Illinois Medicare-Medicaid Alignment Initiative. I hope you found it informative. You may follow me on Twitter at Aging in Chicago, and please subscribe to my blog. Thank you again.